as we mentioned before, the agenda this morning, it's going to be hopefully a not too long meeting, which should hopefully be done by about 11:30, if possible, if not a bit earlier. I'm going to talk a little bit about the trial, the background rationale and where we are. Callum's going to talk about the protocol a little bit, just with some highlights, although the full protocol is available for you to read. There'll be an opportunity for questions, and then some talks led by our nurse co-investigators about opt-out consent, some of the support that we're trying to develop and offer to sites about an education package and training, and then some more of the technical details and next steps before another opportunity for questions. So without further ado, let's rattle quickly through the reason why we're doing this trial. This trial is, as I said, about the practice of regularly and routinely aspirating through a nasogastric or neogastric tube the entire contents of a baby's stomach. And this is pretty common. We did some work, and this trial builds upon a feasibility study that was funded by the NIHR that covered both neonatal units and paediatric intensive care units, which tried to really understand whether a trial of not routinely measuring gastric residual volumes or gastric aspirates would be acceptable and suitable and feasible in the UK. And this concluded that it would be, hence the trial was funded. But it also gave us an enormous amount of useful information about just how common this practice of routinely aspirating the gastric contents is in the UK. We did a big survey, and we had about half of UK neonatal units with a nice spread across tertiary units, local neonatal units and special care units. And what we found is that overwhelmingly the majority of units routinely measured gastric aspirates in some form or other. So they would measure them either after every feed or every 4 hours or every 6 hours or so. And at that time, there were only 4 units that were very clear that they did not routinely measure gastric aspirates. So even the ones where they didn't always do it, there was often quite a lot of varied practice, and some nurses and some doctors would do it. And only a minority of units had any guidance about whether you should measure or not measure gastric aspirates or gastric residual volumes. And that guidance, where it did exist, was a little bit patchily followed. So there's quite a lot of variation in terms of people doing their own thing or doctors telling people to do different things than what was down in the formal guidance. And what we found, again, is there was a great range of how often people did it, but most people did it at some form of regular intervals, commonly 4 to 6 hourly. So that just demonstrated that this was a pretty embedded practice across neonatal units in the UK. And we did some quantitative work with parents and nurses and doctors and other healthcare professionals, and found that it really was quite embedded in practice. And one of the really strong messages that came out from that was that in order to change it, we needed more than just a change in the guidelines, because people felt that they wanted to be reassured that it was safe to stop routinely measuring gastric residual volumes. And in particular, there were concerns about necrotizing enterocolitis. And hence, that was the justification for undertaking such a large trial, so that we can do a trial to really see if there is a difference in terms of detecting and treating necrotizing enterocolitis between measuring routinely and not measuring routinely gastric aspirates or gastric volumes. Before we get to that, though, what's the evidence that this actually is useful and is accurate? Well, if we look at accuracy first, there have been a few studies, and this I think is just a picture of what one of these studies tried to do. And they tried to create a kind of mechanical device that mimicked in a scientifically replicable way the practice of aspirating a nasogastric tube. This is an adult-sized tube, so it's bigger than the ones we would use. And they had a device that put a regular and gentle amount of pressure to aspirate that tube, and they used this cup to be an example of a stomach, and they saw how much of what's in the cup can be aspirated, what proportion. And what they found is that actually it's not very good. Between 40 and 100% is aspirated, and it's quite variable. And actually the smaller tube size, the less that you get up, which I suppose is not particularly surprising, but is quite an important thing to know in neonatal care, where our nasogastric and neogastric tube sizes are often quite small. So I think the first thing to say is, even in this slightly artificial situation, they found that the measurements was not accurately representing what it was trying to measure. It wasn't an accurate content of what was in the cup, which of course in this case was a proxy for what we would hope to be in the stomach. There's been some studies in real life babies, and what they show is that actually it's very influenced by the position of the baby. You get higher volumes in supine babies versus prone babies. Whether that's to do with gastric emptying being different, or whether it's just to do with the way the milk sits, is unclear. And again, there's quite a few studies that have demonstrated that the NG tube size that you use, or the orogastric tube size you use, affects the amount that you aspirate. So if you have a bigger tube, you get more larger volumes, again, suggesting that it's not a good or accurate representation of what's in a baby's stomach at any time. So I think that's the first thing to remember. We aspirate this quite commonly in practice across the UK, and we think that it's telling us what's in a baby's stomach, but actually the truth of the matter is it probably isn't. It's giving us a very mixed picture. And when you aspirate and it's low, it may not be that there's not much milk left in the baby's stomach. It may just be that you're not getting it up. So what's the evidence that this inaccurate and maybe imperfect measure predicts necrotizing enterocolitis? Well, there's been a few studies. Oh, Sujoy, you're back. Do you mind muting, please? There's been a few small studies that have looked at whether routinely measuring gastric aspirates is able to predict subsequent development of necrotizing enterocolitis. And we know from a lot of the qualitative work and survey work that this is a really important reason why people like to measure gastric aspirates routinely. And this was a case control study, so they had 50 babies who had NEC and then 102 babies that didn't have NEC. And what they found was that there were some differences in the days leading up to babies getting NEC, in particular on the day that the baby got NEC, which I guess is not particularly surprising. We know that babies with NEC or any gastrointestinal condition will have high aspirates when they become unwell. But even the higher aspirates in the days before, which people like to think might be used to predict necrotizing enterocolitis and potentially intervene early, there was an enormous amount of overlap, and it was not possible to predict whether a baby was going to get NEC based on the actual volumes. There was no kind of threshold point where you could say this baby is likely to have NEC and this baby isn't. There was so much overlap between them that it wasn't particularly useful. And then there was another study which again took a similar design, a case control study, where they took 17 babies with necrotizing enterocolitis and 17 without. And again, they showed a similar thing, but as you can see from the graph here, lots of overlap in the babies who got NEC and those who didn't get NEC. So no real kind of threshold at which to say, oh, this any aspirate above this amount would be concerning. And they also found more blood-stained aspirates in babies that had NEC. But interestingly, they found a difference in time between the bloody aspirate and the development of NEC of an average of 19 days. Again, just suggesting how difficult it would be to use that to then try and intervene and predict and prevent necrotizing enterocolitis. And again, lots of babies that didn't get NEC also had bloody and bile-stained aspirates, so it wasn't a very useful discriminant measure. So from these small case control studies, we have low quality evidence that it's got limited clinical utility. And what about randomized controlled trials trying to do what we're trying to do in the neoGASTRIC trial? What about trials that have compared measuring gastric residuals routinely compared with not measuring them routinely? Well, there was a Cochrane review in 2019, which had two trials, both undertaken in India, in small babies, but in clearly a very different neonatal setting, and with a predominance of low birth weight babies, growth-restricted babies, as opposed to the more preterm babies that we would see. These were quite reasonably good trials with reasonably low risk of bias. They were quite small, so as you can see here, there's only about 70 babies in each arm of the trials when you combine these two trials together. So it's unsurprising that they're really unable to tell us anything at all about necrotizing enterocolitis, which of course is quite rare, so you need really large numbers to look at it. But what they did find is that in India, in a setting without regular use of parenteral nutrition, where they do try and feed babies quite quickly, that not measuring gastric residuals led to a shorter time to full feeds and actually a shorter time in hospital in these settings. There's been a few other studies that have been done since that. One was done in the US, which was a bit bigger, so 143 babies, again, slightly more preterm population, and they looked at time to full feeds. But the practice at that hospital in the US was to feed babies incredibly slowly. So it took them over 2 weeks, nearly 3 weeks to get to 120 mils per kilo per day, which I think is very different from the practice of most new UK neonatal units, especially for babies that are not even that preterm. And what they found is that not routinely measuring gastric residuals in this single centre study did lead to earlier establishment of full feeds and actually earlier discharge home. They also found no difference in necrotizing enterocolitis, but again, this was woefully underpowered to detect any difference in necrotizing enterocolitis, so that's not particularly surprising. And then another study in India, again, in a small number of babies, about 100, But these babies are a little bit, some more preterm babies there, and they compared routinely measuring gastric residuals with not routinely measuring gastric residuals, and instead just measuring abdominal girth. And again, they found faster time to full feeds and less time in hospital in that setting in India, but no difference in necrotizing enterocolitis again. But of course, very low numbers and only one case across the whole trial. So from these previous trials, which have been done largely in India and one in the US, which is very different settings for neonatal care, and what we're looking at in the UK and Australia, there is some evidence maybe that in those settings, certainly that babies get to full feeds faster. But the big worry that came across loud and clear from the qualitative work, which is that people are worried about missing necrotizing enterocolitis, or that we might not be able to detect necrotizing enterocolitis. There was no data, just because the numbers were so low, to support that, and limited generalizability. Within the feasibility study, we also looked at the trial design, and we did quite a lot of work with parents to identify outcomes, as well as with healthcare professionals. And we were able to identify a set of outcomes that reached consensus as ones that were important. And again, just mirroring all of the work that's been done and everything I've said so far, the one that came out top was necrotizing enterocolitis. People felt that we really needed good quality evidence to show that there wasn't an increase in necrotizing enterocolitis in babies where gastric residual volumes or gastric aspirates were not measured routinely. But of course, time to full feeds would be something that's would be a useful benefit if babies got to full feeds faster. And overwhelmingly across the UK, and I think this has been mirrored by the fact that so many of you here at this meeting today, people were very keen to join the trial if one could be developed. Because we know we want lots of babies in this, and this trial needs to include just over 7,000 babies in the UK and Australia, we wanted to make life as simple and streamlined as possible. So we're using an approach to consent called opt-out consent, which we'll talk a little bit more about a bit later, and Liz is going to give some of our experiences as a site that's been using opt-out consent for quite some time now. We did this in another trial called WEAT, which looks at feeding around blood transfusion. And we did a qualitative evaluation of that within a pilot trial, where we demonstrated, certainly with parents, that parents were very keen to have choice about whether their baby should be in the trial or not. And what they found is that opt-out consent was very effective at giving them that choice. So they quite liked the approach to consent of opt-out because it enabled them to have that choice without it making it feel like it was a really difficult legalistic decision that they had to make. So the principle of opt-out consent was considered feasible and acceptable by healthcare professionals, and parents just wanted the right to decide about trial participation for their baby, and they felt opt-out consent offered them that ability. So this trial will use an opt-out approach to consent, and we'll explain that in a bit more detail later. So where are we now? Well, the reason we're having this collaborators meeting is because we're really poised and ready to go. So we had Research Ethics Committee approval, including the use of opt-out consent in February of this year. And we have the local information packs, which we're starting to send out to sites. I think we've sent it out to 12 sites already. And we have 4 or 5 sites who we are imminently going to be undertaking site initiation visits in the next couple of weeks. We had a small amendment just to update a few of the changes and make sure that we really were measuring the outcomes that really matter. And the plan is to open our first sites next month and then rapidly open sites after that. In Australia, again, we're also very close to final approvals all being agreed, with again plan to open the first sites in May or maybe slightly later, June in Australia as well. So we're really poised to go. We're really excited about this trial, and we're really hopeful that so many of you will be able to open your sites up soon as well and undertake this trial, which, as I said, plans to be the biggest trial ever undertaken in neonatal care across the UK or anywhere in the world. So without further ado, I will hand over to Callum at this point, if that's all right, who's going to talk about some of the protocol highlights. So Callum, is it all right if you just ask me to advance to the next slide, a little bit like Chris Whitty?
Yeah, that's fine.
Is that all right?
Thank you.
Yeah, no problem.
So yeah, thanks, Chris, and thanks for the introduction. And we're obviously very happy to be part of this collaboration across our 2 countries. And you've seen from the introduction, a lot of work has gone into just preparing this trial. So hopefully what you'll see now in the protocol highlights the structure of the trial itself, that we will be able to answer all of those kind of key questions and concerns that people have highlighted need to be addressed We'll start by looking at the inclusion criteria here. So these are the babies we plan to include in the study. We're looking at infants who are born at a gestational age less than 34 weeks, so up to and including 33 plus 6 weeks gestation. And they need to obviously have some form of gastric tube in place to be eligible for the study. Go ahead, Chris. There are a few exclusion criteria to consider, and you'll see one or two highlighted changes as we go through here in red that will be slight variations from earlier versions of the protocol you may have seen. So key things that we wouldn't want to have for a baby who's going to be involved in the study. The infant can't have received more than 15 mils per kilo per day of milk for a period of more than 24 hours. In other words, we're trying to get in early so that we're getting these practices randomized from the start. This is only a minor change from the previous protocol because it was previously worded slightly differently as an inclusion criteria, so not a big change. You'll see that we also want to exclude some other more obvious issues, so gastrointestinal surgical conditions, suspected NEC prior to entry into the study, or indeed focal intestinal perforation, any major congenital anomalies, those infants where we don't anticipate there being a realistic prospect of survival, or of course, in the setting where a parent has opted out of participation in the study on receiving the information about it. Go ahead, Chris. The randomization process here is an individual infant randomization, and they're allocated in a 1-to-1 ratio between the two treatment groups, no routine measurement or routine measurement. And the infant is allocated to continue their allocated treatment pathway basically for as long as routine gastric residual measurement would be standard practice in your center, or until the point where clearly a gastric tube is no longer required, the infant is discharged home, or if none of those apply, until they reach 44 weeks corrected gestational age. So whichever one of those is achieved soonest. And probably worth mentioning on this slide as well that for multiple births, those infants are allocated to the same treatment group. Thanks, Chris. The intervention, pretty simple, and I think you'll all know this part by now. We have the two allocated groups. You can either have routine measurement of gastric residual volumes or no routine measurement of gastric residual volumes. Go ahead, Chris. And I think Chris highlighted the importance of this point earlier. What do we mean when we say routine measurement of gastric residual volume? We're talking about the practice of routinely measuring every 4 to 6 hours the stomach contents, aiming to aspirate the whole stomach contents, although as Chris highlighted, that doesn't always happen. And specifically, we're not talking about the practice of getting a small aspirate back to test the pH, confirm that your gastric tube is in a safe position for feeding. That is absolutely allowed within the study. Go ahead, Chris. Now, how are we going to deal with assessing feed tolerance or intolerance in the group of babies who are allocated to no routine measurement? Well, of course, there are a number of other clinical signs that we'll be familiar with assessing in this population. They include vomiting, abdominal distension, pain, discomfort, change in bowel movements, whether that's appearance of stool, failure to pass meconium, change in bowel sounds, or indeed other changes in the baby's clinical status, for example, changes in blood gas, metabolic acidosis, lactate changes. And all of these type of issues should really prompt review by an experienced clinician, as I'm sure would be the normal practice in your centers, because of course babies are a bit non-specific in terms of how they present with things, and some of these will be a manifestation of something quite different to feed intolerance. So any kind of abdominal concerns like this, and you'll see from the treatment chart included in the protocol, should be prompting review by a senior clinician or an experienced clinician, however you choose to define that in your particular center, before you actually get to the point of stopping feeds. Thanks, Chris. Go ahead. So what are our objectives here, or indeed our key outcomes? The primary outcome of the study is the time to achieve full feeds, and that's achievement of full feeds over 3 consecutive days. And there is also a key secondary outcome, which is the incidence of NEC. And in fact, the study is powered for both of those outcomes to detect superiority in achievement of full feeds with a reduction in time of 1 day, but also with a non-inferiority sample size calculation for NEC with a margin of non-inferiority, which is 1.5%. There are, of course, a number of other secondary outcomes, and I think if we move to the next slide, Chris will highlight some of those. They are the ones that you might expect in this population and in a study focused on feeding. So as you can see, severe NEC leading to death, any mortality, focal intestinal perforation, GI surgery for any reasons, also late onset infection, a variety of other duration of stay or duration of intervention outcomes. We do look at central line time and growth parameters. And if you go to the next one, please, Chris. Just to highlight, there's one update on this slide that wasn't in there previously, which is significant brain injury, so IVH grade 3 or 4 or cystic PVL, which fits into those other important neonatal outcomes, perhaps not directly related to feeding as such, but could be related to acuity of the baby during the course of stay. And a number of other feeding outcomes, breastfeeding outcomes, receipt of maternal breast milk at discharge home. So the outcomes you might expect, I would say. Thanks, Chris. Go ahead. We also, of course, are interested to know a bit more about the economic aspects of this study. So looking specifically at a health economic evaluation, both in the UK centres and the Australian centres. So we have teams in both countries. And we'll look at things like the number of gastric residual volume measurements that are required, use of investigations such as X-rays, use of antibiotics, surgery for NEC or perforation, and really all aspects of healthcare costing to see if there is in fact a cost implication as well as a clinical outcome implication in either of these treatment arms.